Very good morning to everybody. Thank you for joining for our Breakfast Health. Today is my pleasure to introduce Dr. Cheng. He's one of our University Malaya born undergraduate, postgraduate, and currently she's at the United Kingdom doing a subspecialty training. And she also is the latest APRS Young Investigator Award winner. And her patient is always in the scarring of the lung, and hope she'll enlighten us today regarding the progressive pulmonary fibrosis. So what is the latest and what we can do better for our patient in University Malaya? Dr. Sia, I would like to invite you. Thank you.
Thank you, Dr. Vijayan, for the kind introduction. Good morning, everyone, but good evening from London. I'm going to talk about progressive pulmonary fibrosis, PPF, beyond idiopathic pulmonary fibrosis, IPF. I think this topic is very relevant to me because I'm now pursuing my subspecialty training in Royal Bolton Hospital. And yeah. So these are outline of my presentation. I will tell you the definitions and also the differences between IPF and PPF, followed by a case illustrations, the importance of identifying PPF, what are the PPF criteria, where do we stand in Malaysia, and what to move forward. Is an unknown idiopathic interstitial lung disease, ILD, is primarily affecting male patients more than 60 years old with a history of smoking. And this disease demonstrates usual interstitial pneumonia pattern from the HRCT. The median survival in these conditions is poor, which is 3 to 5 years. So it could be as poor as patients with lung cancer. How about PPF? PPF is actually not a disease, rather than a phenotype which show progressive pulmonary fibrosis with or without non-etiologies, and certain criteria are required. It's either a standalone criteria or multidimensional criteria, which I would elaborate further. There's a wide range of the prevalence ranging from 15 to 30%. So up to perhaps I would say 1/3 of the non-IPF patients has PPF. And in a short word, PPF is non-IPF ILD, which confers similar prognosis as IPF. So this diagram to illustrate you the categories of non-IPF ILD. You can see the left figure, which is our interstitial idiopathic interstitial pneumonia. It includes all the idiopathic causes of non-IPF ILD, such as idiopathic non-specific interstitial pneumonia, idiopathic pleural parenchyma fibroelastosis, idiopathic dyschromatic interstitial pneumonia, cryptogenic organizing pneumonia, lymphocytic interstitial pneumonia, and so on. The second category is autoimmune ILD, which include rheumatoid arthritis, systemic sclerosis, mixed connective tissue disease, myositis-related ILD, Sjogren's, vasculitis, SLE, and others. The third category is exposure-related. The commonest is hypersensitivity pneumonitis. Others include occupational-related ILD, such as asbestosis, silicosis, coal miner, berylliosis, medication-induced, radiation-induced, drug-induced post-infectious, and respiratory bronchiolitis ILDs, which is another smoking-related ILD. The fourth category is ILD with cyst and/or S-phase filling, which include Langerhans cell histiocytosis, lymphoproliferative disorder, pulmonary alveolar proteinosis, lymphangial leiomyomatosis, and others. Last but not least is sarcoidosis, which is more common in Caucasians and also Indian ethnicity. So this slide to illustrate you the complexity of these PPF conditions. Of course, IPF behavior is like PPF, but in the practice, PPF does mean anything non-IPF ILD, but behave similarly like IPF. To better understand PPF, I'll just illustrate you a case that I saw recently. Mr. Ian is a 53 years old man. He's a case of anti-synthetase syndrome with muscle and lung involvement. He presented with respiratory failure in 2012. Subsequently, he was stable on treatments, which include intravenous immunoglobulin, mycophenolate, mofetil, as well as prednisolone. He has been stable over the years. However, in the recent visit, he was noted to have worsening lung function test and a HRCT. So what is the impression at these junctions? So before we move on, we just want to talk about why PPS matter. So it's important to recognize these conditions because, as I say, it confers poor prognosis. If you could appreciate the figure on the left, which show you different prognosis in different ILD subtypes. CTD-ILD usually confer better prognosis and IPS has a poorer prognosis. But after adjusting one of the PPF criteria, such as the 10% relative change of the forced vital capacity, FVC, you can see the prognosis approximate IPF on the figure on the right. The second reason why we need to identify PPF is because there's available treatment. So the only antifibrotic approved in this condition is nintedanib. So it's from the inbuilt trial. It demonstrates that the treatment group patients actually have a slower progressions of the FVC reductions compared to the placebo. The other antifibrotic, sulfamidones, is not approved in PPF, but in IPF. This is because in the phase 2 trial, in the relief trials, there is an early termination of the studies because of the slow recruitment. As for the UILD 2021, which the cohorts include unclassifiable ILD with progressions, they couldn't achieve the primary endpoint. So because of that, nintedanib is the only antifibrotic approved in PPF. Apart from that, supportive treatment could be offered to patients with PPF. The first one is the pulmonary rehabilitations. A lot of data from COPD, and in COPD patients, even pulmonary rehabilitations proved to have a survival benefit. Although we do not have the data to show that pulmonary rehabilitation could improve the survival, but there are few studies shows it can improve the patient's exercise endurance as well as the quality of life. Oxygen support also can be offered in this group of patients. In MBOX trial, which is the only randomized control trial, study in among the patients with PPF shows that the oxygen support actually can improve the patient quality of life as well as the endurance in the exercise. Fourth point that I want to bring to attention is early lung transplant referral. Any patient diagnosed with PPS should be referred to a lung transplant center. At present, we have 2 centers in Malaysia, which are Sedang Hospital and Seremban Hospital, receiving lung transplant referral. So if any patient diagnosed with a PPS, early referral will be beneficial to them because the transplant window is very narrow. We don't want to refer the patient too late, or else the patient will progress very fast. The fifth point I want to bring up is the enrollment into the clinical trial. as you can see, the PPF ideas had just introduced in the past, maybe less than 1 decade. So there are a lot of ongoing trial to study this disease. For example, fibroneal ILD, which just completed the study about 1 or 2 years ago. I heard that the result is positive, and there are other ongoing study in PPF. So if we could identify the patient could benefit from the clinical trial. This picture to highlight that assessment in PPS isn't easy because it requires the effort from the patients as well as the operators. So the patient need to be instructed and draw the spirometry with the effort. So in the patient with that very few, sometimes it will be difficult to perform a lung function test to assess their conditions. Before I talk about the PPF criteria, I just want to highlight that it consists of 3 main domains. The first one is the clinical symptoms. The patient presented with worsening shortness of breath or cough, it may indicate that the patient had PPF. The second one is lung function test. So if you can see the graph that I share here, it just show you the trajectory of the FEV1, FVC, and gas exchange TLCO of the patients. And because sometimes there will be intra measurement variability, so that a trajectory of the reading will be very helpful to predict whether there is a genuine decline in the patients. The last one is the CT scan changes, and you can see this one of the patients who have some fibrotic changes, and the progression of the fibrosis is also another criteria for PPF. So go back to our patient, Mr. Ian. You can see the lung function test over year in November 2023, September 2024, and in February 2025. The FVC and DLCO has declined over times, and if you could use a calculator to calculate it, it's actually absolute decline of FVC in 7% of FVC decline, as well as 13% of DLCO drop. How about the CT scan finding? So the CT scan finding of Mr. Ian's compared to 2023, he clearly has a progression, isn't it? Because there is an increase in reticulations, also white patch over the left lower lobe. So unlike PDM staging in lung cancer, we could predict the patient prognosis, sometimes it's very difficult to identify this group of patients. Hence, in the past few years, finally, we have 2 main criteria to identify PPF patients. So the left column, I would like to show you the first criteria to try to identify this group is from the inbuilt trial. And it was a criteria designed for the clinical trial, but the criteria have been used to identify this group of patients. The durations of the criteria must be within 24 months, and the patient must fulfill a few criteria such as at least 10% of fibrosis, 45% and above of FVC, because they do not want to recruit a patient with very poor lung function test and then may not show any benefit from the antifibrotic, and DLCO of 30 to 80%, non-IPF ILD, and any patients fulfill one of the below criteria, they are deemed to be having progressive lung disease. As for the right column, you could see is another criteria by Rahut et al. It's an international guideline, and this guideline is to better shed light in identify PPF, and The duration is slightly different from the clinical trial. The progression need to be occur within 12 months, and any two of the below criteria would deem to be a PPF. The first one is a worsening clinical symptom. Second one is absolute decline in FVC of at least 5% or more, and also absolute decline of DLCO of 10% or more. The last one is the radiological changes suggestive of progressions. So you could see the main difference between these two is actually relative decline and also absolute declines. I think because of the time constraint, I wouldn't elaborate more what's the difference between relative decline and absolute decline. So in this guideline, it better illustrate what are the criteria of radiological progressions, such as increase in extent of the traction bronchiectasis and bronchiectasis, new ground glass opacity with traction bronchiectasis, new fine reticulations, increased coarseness of the reticulations, increase in honeycombing, or any volume loss. Just to highlight that worsening symptoms and also DLCO decline are less specific because it could be due to other lung conditions such as pulmonary hypertension or heart failure. So go back to our patient, Mr. Ian. What is the etiology in this case? It's clearly a myositis-related ILD because of antisynthetase syndrome. And his clinical diagnosis is PPF because he fulfilled the two criteria. First is the worsening of spasticity. Second is the FVC and DLCO reductions. The next step, obviously, we need to start antifibrotic in this patient to slow down the progressions of the lung functions. Where are we? Do we have a local data on PPF? I'm pleased to share with you the paper that we present in Asia Pacific Respiratory Society conference last year. So yeah, this study actually shows that CTD ILD is the commonest non-IPF ILD in our hospital, followed by unclassifiable ILD, other IIP, hypersensitivity pneumonitis, sarcoidosis, and others. So in our cohort, we found that hypersensitivity pneumonitis confers the poorest prognosis with a mean survival of 6 years, which is almost similar like the median survival of IPF. And in future, where are we in terms of PPF in Malaysia? So far, we do not have any data on PPF available. We have officially launched a nationwide studies called MEL Project, Malaysia Interstitial Lung Disease Project, over 23 centers. And we hope that in the near future, we could shed some light on the incident, prevalence, and type of the PPF in Malaysia. So this is the take-home message from my presentations. First, PPF is a progressive life limiting conditions beyond IPF. Early diagnosis and intervention are crucial because, as I say, it carry poor prognosis, and there are actually available key treatment strategies such as antifibrotics, pulmonary rehabilitations, oxygen therapies, and early lung transplant referral. There are still ongoing research and clinical trial, and hopefully with all this research and clinical trial, it can show a better future for PPF despite this being a poor prognosis conditions. Okay. With that, I thank you for your attention. So this is the photo I took outside of my hospital in London, and I welcome you if you have any question. Thank you.
Thank you very much, Dr. Sia, for the excellent presentation. So I think we give any Q&As for now.
I think there's something to trouble. No, no question.
No questions. Yeah. There's such, I think we allow the second presenter to proceed with the presentation. If there are any questions at the end of the second presentation, we might take and answer the questions. Thank you, Dr. Sia. Hope you're doing well. How the weather there?
Yeah, thank you, Dr. Vijayan. Thank you, everyone.
Okay. We miss you. Oh, yeah.